Welcome to, friends to today's seminar. Today's webinar is a case presentation, and the case is from Artemis Hospital, Gurgaon ICU, moderated by Dr. Jitendra Sharma, who is head of critical care there, and will be presented by Dr. Swati. She is a final year DNB student in critical care. So, Dr. Swati, please start. Dr. Jitendra, please unmute yourself. Yeah. Okay,
Yeah.
Dr. Swati, start.
Yes, sir. So good evening. I'll be presenting a case the case has a history of 64-year-old male who was an international patient admitted with complaints of dull sensorium and extreme lethargy. He also had complaints of high grade fever, which was not associated with chills but associated with diffuse abdominal pain and also associated with decreased urine output since the last 3 days. Sorry, sir. He, with a background of 10 days back, he underwent a distal radical gastrectomy with modified lymphadenectomy with Roux-en-Y retocolic gastrojejunostomy with site-to-site jejunojejunostomy with feeding jejunostomy for carcinoma stomach. Postoperatively, the postoperative period was uneventful, and he was discharged on postoperative day 5 in a stable condition with no known comorbidities. On examination in the ER, the patient was cold, clammy extremities with a poor sensorium of GCS of 14 by 15, tachycardia, heart rate of 138 per minute in sinus rhythm. The non-invasive blood pressure was 80 by 45 mm of Hg, and the capillary refill time was more than 3 seconds. On ABG evaluation, patient had an metabolic acidosis plus lactic acidosis, the pH of 7.23, PCO2 of 23, bicarbonates of 18, lactates of 5, with a normal sodium 130 and a potassium of 5.2. Respiratory system wise, he was tachypneic with a respiratory rate of 40 per minute with a saturation of 89% on room air. Auscultation wise, there was bilateral air entry, but fine crepitations were heard in bilateral basal zones. Abdomen was distended, tense, tender in epigastric and the left hypochondric region. Guarding was present with a sluggish bowel sounds. The feeding jejunostomy site was clean. Cardiovascular system wise, he was hemodynamically labile with a normal S1 and S2 with no murmurs. Renal wise, the urine output was decreased to less than 0.3 ml per kg per hour over the last 3 hours since the admission.
So just okay, next slide. No, last slide before that.
Yes, sir.
Just go to the first slide.
Yes, sir.
So pain abdomen, what else you want to ask us other than associated with posture?
Yes, sir. If it was any associated with any posture, if it was associated with bending forward, mostly in pancreatitis, there is positional change which causes pain abdomen. It gets relieved when the patient tends to bend forward.
That is not the, I don't think that happens in pancreatitis. Where did you read that? That is not a feature of pancreatitis. Which pain is related with posture change? So renal colic is associated
Yes.
with posture change. Pancreatitis is, I don't think that is correct. That is related by leaning forward. Okay, so what else you want to ask in pain abdomen apart from posture?
So, what kind of pain it is? If it is a colic pain or a diffuse
Hmm. What
pain,
else?
the character of the pain.
Hmm. And
Also,
radiation.
yes, so the radiation of if there it is any radiation associated or if it is associated with any aggravating or relieving factors.
So what other aggravating and relieving factor? So one is posture. Well, then what else?
So associated with feed, if the patient
Yes.
has gastritis or the gastric ulcer pain or the peptic ulcer pain, it will be associated with feeding habits.
Yeah, so that also has to be asked. Okay, so radiation
Yes,
has to be asked, and any posture change that you have asked, and posture is more related to renal colic classically, and
yes,
food, any relation to food. So these things are important when you ask about pain. Okay,
yes.
and fever you have asked, and sensorium is dull and extreme lethargy. Next slide. So if the patient has cold, clammy extremities with the hypotension, what is the first diagnosis?
The shock is there, so there is hypertension or the shock is present. It
What
could
kind of
be
shock is there with cold, clammy extremities?
so mostly the septic shock is present with
Septic shock classically has cold, clammy extremities, or some is what kind of extremities?
it is
When what kind of extremities are present in septic shock?
so warm extremities are usually present
Yes,
distributed.
warm extremities are present. Why warm extremities?
So because of the vasodilatation, peripheral vasodilatation, there is warm extremities.
Okay, and what shock is associated with cold, clammy extremities?
So cardiogenic shock.
Classically called cold clammy is with cardiogenic. Any other shock is associated with cold, clammy extremities?
Uh,
So technically, it is a hypoperfusion, either
hypophonia.
cardiogenic or overall circulating volume is low.
Yes, sir.
So even hypovolemic and hemorrhagic shock can be associated with cold, clammy extremities, right?
Right, sir.
So in what weather did the patient came? Patient came in the cold weather.
Yes, sir.
So when the temperature itself is cold, and you are having the patient winters, then extremities, cold extremities don't have so much meaning. Even septic shock will become cold extremities. Huh? Ambient temperature is important, right? If the patient is coming from outside exposed to cold, then extremities will become cold. Okay.
Yes.
And the other thing is, he was having fever. How much fever?
So high grade fever, which family had not recorded at home, but according to the family, it was high grade.
Okay,
It
but
was
you have
not.
not mentioned the temperature.
Uh, so in the ER, the patient was febrile in the ER actually, but according to the family, he had a history of fever,
So
high
that is
grade.
important, right? Patients always complain of fever at home, but they don't have fever many a time. And the recording of fever is very important. Any patient who's sick, they will say he has fever. So there is no fever recorded. Okay. Now, when the fever is not recorded, what are the problems with fever? That what kind of temperature is taken normally when in the ER or in the ICU?
So the axillary temperature is
So is
usually is
axillary
recorded.
temperature accurate?
No, sir, it's not accurate.
It is
It's
not accurate. So that is
yes,
another
sir.
problem with recording of fever. Okay, but if there is fever of 100 to 103, it will show up in the axilla also. Okay.
Right.
Okay, then coming to your blood pressure. So, Dr. Jitendra, you want to make any comments or any questions, sir?
So, so technically, one more kind of a pain abdomen, especially localized to the epigastrium. So, uh, non-abdominal in origin can also be considered, especially the inferior wall MI can also have a epigastric pain. So in this
Yes,
case, of course, it is diffuse, but one of the things one should keep in mind in acute care setting.
right, sir.
So,
So
if the
when
patient is having diffuse pain, what does that mean actually, Dr. Swati? Coming to pain again.
So it is not localized to one particular region of the abdomen. It is diffusely present throughout the
So,
abdominal
what
compartment.
does that indicate? What kind of pathology is lying in the abdomen? Which pain is associated with diffuse pain? What is the
Uh,
organ involved?
uh,
So, most likely it is peritonitis, right?
right, sir.
Okay. Now coming to your blood pressure 80 by 45. So the diastolic pressure is normal or it is low? Any
So,
comment?
so it is low, sir. Diastolic blood pressure is low.
So a 45 diastolic pressure indicates what kind of shock?
So distributive shock is there.
Okay. So distributive shock are of what kinds? What are the types of distributive shock?
Uh,
so distributive also
distributive.
subclassified into the primary vasodilatory, primary capillary leaking, or the combination of these.
Right, sir.
So if so much low diastolic pressure, then the predominantly it would be vasodilatory.
Right, sir.
So what are the types of vasodilatory, Dr. Swati? So
So
septic shock is one, right?
right, sir.
What are the other two types?
So vasoplegic shock or
So
hypo.
vasoplegic is vasodilated. What is vasoplegic?
So because of the excessive vasovagal reaction, they will be with peripheral vasodilatation leading to shock.
No,
So
vasovagal.
pure vasodilatory shock without capillary leak is what do you find in the anaphylaxis? Is capillary leaking is there in anaphylaxis or not?
Yes, sir, capillary leaking is
No,
present in
doesn't capillary
anaphylaxis.
leaking won't happen within a few seconds. It's a purely vasodilatory shock.
Right, sir.
So Swati, there are three types of vasodilatory shock. One is septic shock, which is most common. Second is anaphylactic shock, and third is neurogenic shock.
Yes, sir.
Vasovagal is not shock. Vasovagal is just a
Yes.
momentary thing. It is not classified as shock. Okay.
Right,
Vasovagal
sir.
reaction you can get in extreme distress, extreme, emotional discomfort, or when you see pain, suddenly patient collapses sometimes. So that is not a shock classically. That just happens over a few seconds, and that is that has bradycardia and hypotension. But vasovagal reaction is not a type of shock. Huh? Shock
Yes, sir.
has to be there for some vasovagal occurs in a few minutes. Okay, patient gets vasovagal discharge and he has hypotension, bradycardia, and collapses. That's called syncope actually. Okay, so syncope is
Right, sir.
not the same as shock. So vasodilatory shock is of three kinds: septic shock, which is commonest. Rarely you have neurogenic shock, and you have distributive shock. You have anaphylactic shock. And
Yes, sir.
in neurogenic shock, when do you get neurogenic shock?
Uh, Sir, in cases of subarachnoid hemorrhage, there will be neurogenic shock.
Why do you get
Uh,
neurogenic shock in subacute hemorrhage? Dr. Tushar, welcome. Please unmute yourself. So, Dr. Tushar, we are talking
Hello,
about
sir.
of
Yeah.
shock. So, we are talking about neurogenic shock. So, you know when you get neurogenic shock?
Sir, spinal cord injuries.
Yes. So,
Yes.
why should you get in subarachnoid hemorrhage?
No, sir, not
Yes,
in
not in
spinal cord.
subarachnoid hemorrhage.
In spinal cord injury.
In spinal cord injury. Okay. Any other condition?
Uh,
So neurogenic shock you can also get in certain kinds of viral infections whenever when you know the autonomic nerves they get paralyzed. Sometimes you get acute viral infections, and viral infections may be associated with involvement of the nerves. The autonomic nerves they get involved, and there's a vasoplegia. So that's a very rare cause, but just to take it forward and just to highlight some of the unusual causes. Usual cause is spinal cord injury. Okay. And
right, sir.
also you get in GBS. GBS also can be associated with a neurogenic involvement. Okay.
Right, sir.
Now moving
Yes.
onwards, 80 by 45 in a 60-year-old lady, you said, huh?
Yes, sir.
And there is tachycardia. So now looking at all this, the history, she has fever, she has hypotension with low diastolic pressure, she has tachycardia, she is, having this thing, dull sensorium. What kind of shock do you think she has?
Sir, not, sorry, because of the with the background of history of a post-operative, the patient had undergone surgery 5 days back, associated with fever, lethargy, with a altered sensorium, heart rate, and low blood pressure. Probably it could be a septic shock.
It could be septic shock. Okay.
Could be
So,
septic. It can be a hypovolemic also. Possibility is there.
Yes, sir.
so what about hemorrhagic shock? She had undergone surgery. Maybe some vessel has opened up. Can it be hemorrhagic shock?
But surgery has been done 4 or 5 days back.
Yeah, but that is true. But you cannot rule
Yeah,
it out. Yeah.
secondary
Yeah.
hemorrhage can be there.
Some kind of
Right.
hemorrhage may have occurred now. Maybe there was a slow leak earlier and now it has opened up. So is it possible hemorrhagic shock, hypovolemic shock? They are also
Yes,
possible, huh?
right, sir.
What about cardiogenic shock? Is it possible?
Cardiogenic shock also could be possible, sir, because on examination the cold extremities and everything is there, sir.
But there is fever. What about
Fever.
fever? Do you get fever in MI?
Sir, not commonly, fever is not commonly seen in an patient, so
Is it seen or not seen, fever in MI?
So it can be seen, but it's not very common, sir. It's not absolutely, it cannot be ruled out.
Fever can be seen in MI, okay? Fever can be associated, MI can be associated with fever. All right.
Right, sir.
Now, but what is against cardiogenic shock? Dr. Tushar?
Uh, so,
Are you aware of the patient?
yes, sir. Yes,
So
sir.
the blood pressure is 80 by 45. Is
Yes,
this
sir.
compatible with cardiogenic shock?
Uh,
With cold clammy extremity?
diastolic pressure is slightly on the lower side, sir.
Very good. So diastolic pressure.
Classically in cardiogenic shock, what would be a pressure parameters for that? Classically, it would be a low pulse pressure.
Yes, sir.
Something like 80
Yes,
by
sir.
60 would be seen in cardiogenic shock, not 80 by
Yes, sir.
45. Huh? So anything less than 50, if you get diastolic, that is really in favor of a vasodilatory shock.
Yes, sir.
And 95% of the time it will be septic shock. Normally the cutoff is taken as 50. Diastolic,
Yes.
no diastolic for vasodilatory shock. It can be more than 50 also. You
Yes.
can get septic shock with 60 diastolic also, but if it is less than 50, then it becomes more or less vasodilatory shock. Now, coming to shock in sepsis, okay, septic shock. So, what kind of hemodynamics do you get in septic shock, Dr. Swati?
Sir, in septic shock, sir, the systolic as well as the diastolic pressure both will be decreased with narrow pulse pressure.
Okay, what happens to cardiac output?
So technically, septic shock you divide into the two part. Mainly the early septic shock, and eventually the later part of the septic shock is superimposed by the cardiac dysfunction, and eventually it will mimic the combination of the low cardiac output state and the. So classically, the early septic shock would be is it a high cardiac output state or low cardiac output state?
Low cardiac output state.
Early would be a high cardiac output state. So early septic shock would be a predominantly your distributive, vasodilatory, and the capillary leak, and you will find a high cardiac output state. That's why the central venous saturation is a little bit higher side in the initial part of the septic shock, and the later part.
So what happens to the cardiac output in the early stage, Dr. Swati, in septic
So
shock?
yes, sir, in the early stage, as I said, the cardiac output will be higher, sir, because of the distributive kind of pattern, sir. There will be high cardiac output, sir.
So what are the components of cardiac output?
So the cardiac output is equals to stroke volume into the heart rate, sir.
So why the cardiac output is high in the early stages of septic shock? Because of what?
So the heart rate is higher in the initial phase of the septic shock, sir. With us, the stroke wall, the peripheral vascular resistance is but decreased.
So the stroke volume is more or less normal, heart rate is increased. So that is
Yes,
why
sir.
you have high cardiac output,
Yes,
right?
sir. Right, sir.
So there is a leak, capillary leak going on. Huh? So
Yes, sir.
intravascular volume is decreasing,
Yes.
right? But what contributes to maintaining the intravascular volume? Something happens, there is something going on which maintains the intravascular volume to some extent in the initial stages. So what is that?
Sir, there is plaque vasoconstriction will be having. There will be redistribution of the blood.
Okay, so there is venoconstriction and there is recruitment from the, there is a stress volume and there is an unstressed volume. So unstressed volume from the abdominal vessels and the veins, they get recruited. The unstressed volume gets recruited into the stressed volume. So that is in the initial stages. And after that, what happens if the patient comes late?
So there will be vasoplasia leading to the vasodilatation, causing fall in the peripheral vascular resistance.
That is there from
Further
the
fall in
beginning. So, Dr. Swati, once septic shock comes, there is vasodilatation. Okay, it's a vasodilatory shock
yes, sir.
right from the beginning. But Dr. Jitendra mentioned something. Initially, there'll be high cardiac output, but if the patient comes late, there'll be a low cardiac output. Why do you get a low cardiac output after some time?
So the
So you get a low cardiac output because the fluid keeps leaking, and the intravascular volume becomes low.
yes, sir.
So the stroke volume cannot keep up with the required cardiac output.
Yes, sir.
Any other
Yes, sir.
reason? Dr. Tushar?
And the both the combination, and eventually myocardial dysfunction also happens. So that's why in the sepsis there is a little bit rise in the both the things. Myocardium get injured, that's why trophi little bit rise, and the antiproBNP also rise, functional and anatomical, both the things, and myocardial dysfunction happens. And that's why when now we are frequently doing the echocardiography in the ICU, and then we find most of the patient they are having a low ejection fraction, and really not the acute. This is not because of the acute coronary syndrome or the coronary. So mostly patient who is not aware about that. That's why we are discussing. We must be aware about this fact. Otherwise, what happens? We seek unnecessarily cardiology consultation, and unnecessarily these patients are loaded with the antiplatelets. But it is not because of the acute coronary syndrome. It is a functional myocardial dysfunction.
So as one progresses, you may get myocardial dysfunction. It does not occur in all the patients, but some patients will develop cardiomyopathy, what is called septic cardiomyopathy, and EF will drop, LVEF.
Yes,
Even you may get right ventricular dysfunction, and sometimes you may not get systolic dysfunction. You may get only diastolic dysfunction in either the left ventricle or the right ventricle or both. So cardiac involvement in septic shock is of variable kinds. Commonest is LV systolic dysfunction. And if the patient comes late, some patients will come within the first few hours. Some patients may come after 2-3 hours. Those patients may already have septic cardiomyopathy with a low EF. And the fluid may have already leaked out with a low circulating volume, and they may have a low cardiac output in the beginning itself. And when they have a low cardiac output, the extremities will be cold and clammy. So this patient may be having septic shock going on for a few days, couple of days or more, slowly evolving. And that's why she has a cold, clammy extremity. That is one of the reasons. The other thing is the weather is cold, so that can lead to cold, clammy extremities. So these are
Yes,
some of the explanations. The other thing is if so abdomen, she has a feeding jejunostomy and urine output has decreased. So
Yes, sir.
is she in acute kidney injury as per
Uh,
you?
yes, sir. Yeah, God. There is decrease in the urine output to less than 0.3 ml per kg over the last 3 hours. Yes, so there is with a history of also there was fall in the urine output over the last 3 days. So yes, sir, there is acute kidney injury at present.
No, but urine output, if you look at your statement, 0.3 ml per kg per hour over 3 hours, is that correct? By that definition, is she in AKI?
Uh, so for the criteria for the grading according to the KidGo, it will not be in
Yes,
the
it has to be 6 hours, okay? It is
yes,
not
sir.
3 hours per urine output. So this is not past history you cannot rely on. You have to go by objective criteria. So urine output less than 0.3 over 6 hours is the urine output criteria. And then you have the creatinine criteria. So those
Yes,
the
sir.
other criteria are also there. But urine output criteria is this 6 hours at least. And coming to what else is the go to the first slide? So GCS is so international patient diffuse pain abdomen and decreased urine output we have discussed. Why is the sensorium dull?
So because of the hypoperfusion state, this patient could be having dull sensorium.
Any other reason?
So because of the high grade fever, the patient who had a history of high grade
No,
fever.
no, there is no fever documented. So you leave the fever. Fever is not reliable currently. What else?
Right. So because of the AKI, there is decrease in the they could be higher, increasing urea levels, which could be causing altered sensorium.
We do not know the urea, so it is unlikely that the patient is coming in progressive acute kidney injury with so much high urea that she has gone into uremic encephalopathy. Anything more than that, more reliable and more sensible? So, Dr. Tushar, why is the sensory apart from hyperperfusion?
Because of the septic encephalopathy, it could be one of the reasons. Because of the cytokines release, it can cause encephalopathy. Otherwise, another cause could be dyselectrolemia. That could be one of the cause. Also, the patient is post-operative period POD4. That could be one of the causes we can keep.
Septic encephalopathy is the other reason I correctly said. So one is hypotension, second is septic encephalopathy. Uremic encephalopathy we cannot say unless we see the urea values and all that. So next slide. So capillary refill time greater than 3 seconds. What does that mean?
So that the peripheral perfusion is hampered, sir. There is decrease in the normal capillary refill time should be less than 3 seconds, sir. But if it is more than 3 seconds, that it signifies there is peripheral hypoperfusion.
Okay. So the microcirculation flow is not good enough. So you know of any study which has shown capillary refill time to be a good marker of peripheral perfusion?
Sir, the Andromeda study which was done showed that the capillary refill time was had a good predictor.
So Dr. Jitendra, any comments?
I,
Ask.
Yeah, but this capillary refill time is actually, one should be very sure there will not be any peripheral vascular disease. Otherwise, it gives a false positive for this thing. And one of the marker, but again, especially in the initial time and of course the other confounder environment and all these things should be kept in mind. So trial was done under the controlled condition. So generalization of trial may or may not be possible all the time. Of course, the trial has shown that there is a good correlation between capillary refill time and the occurrence of the shock during the study population.
So, Dr. Swati, capillary refill time greater than 3 seconds. How will you use this now? If the capillary refill time, what is the significance of measuring it?
Sir, with resuscitation, this capillary refill time, the target should be less than 3 seconds, sir. So, in the places where the invasive monitoring cannot be done, or the echocardiography or the lactates cannot be estimated in those places, the capillary refill time can be used as a surrogate marker for peripheral hypoperfusion.
So, how will you use it here? What will you do now if this is the situation? Capillary refill time more than 3 seconds.
So the resuscitation has to be initiated for the patient, sir.
With what resuscitation?
The IV fluids resuscitation has to be initiated for the patient.
Okay. So, you start the resuscitation, you are given around 1.5 liters, capillary refill time is still high, then what to do?
So start with the vasopressors, sir. Noradrenaline would be the choice, but to start with the vasopressors.
So if the capillary refill time remains high and it is not normalizing, does that mean you keep on giving fluids even at 20?
No, sir.
Huh?
No, sir. No, sir. It will not. It has to be. It has to be, sir, under the echocardiography or dynamic parameters. We have to monitor other parameters also to decide how much fluids has to be given further.
Okay, so at some point on time, you have to look at other markers also. You cannot just keep giving fluids. So even if the patient's central volume gets filled and the peripheral circulation is not getting filled, like capillary refill time is greater than 3 seconds, why that happens?
Uh,
You understand the patient's volume, the central volume may be fully resuscitated, but the capillary refill time may still be happening more than 3 seconds. So why does that happen?
so because of the vasodilatation, which is already there because of the septic shock.
Vasodilatation is there
Once
everywhere.
we
Sorry, peripheral vasoconstriction, what happens, which will cause capillary refill time to be persistently more than 3 seconds.
No, once we adequately resuscitated fluid wise and still it is a high. So what else we can do?
So we can start with the vasopressors.
So vasopressor will be constrict the vasopressors. So ultimately the capillary refilling time is the marker of perfusion.
Yes, sir.
How you can increase the perfusion if you already ensure the volume? Then it would reflect the cardiac output.
Yes, sir.
So the you add those medication or those intervention will be done, which increase
So
the cardiac output.
cardiac arrest. So dobutamine can be initiated to increase the cardiac function, sir.
Devices, the dobutamine.
Upper.
So the other thing is, one is like Sir has said, you can assess whether the peripheral perfusion is adequate or not adequate. That can be determined, and you can add dobutamine if the cardiac output is low. That is one thing. The other thing is there is something known as dissociation between microcirculation and macrocirculation. Okay, the macro circulation is all your central pressures and all that, central volume. So that may be adequately filled up. But there is a problem with the micro circulation. There is shunting, there is vasoconstriction. So your capillary refill time does not go less than 3 seconds, despite your adequate resuscitation. There's a dissociation between the macro circulation and the micro circulation. And this starts within a few hours. Generally, after 12 hours, you will have a dissociation between your microcirculation and macrocirculation. Initially, you may not have. Initially, when the patient comes early, you will not have. So your peripheral capillary refill time will reflect correctly upon the central volume. But as time goes by, there will be a dissociation between macro and micro. So you will not be able to use it. Capillary refill time and it may remain high despite adequate resuscitation. All right. And it
Yes,
has
sir.
been shown, Andromeda study has shown, and other studies have also shown that capillary refill time is better than lactate and even your, venous saturation gap. We use venous saturation gap also at times to study the peripheral perfusion and CO2 gap. So capillary refill time, one must know how to do it. What are the caveats? Like Sir had said, the ambient temperature, the peripheral vascular disease should not be there. All these things are there. But you cannot keep on giving fluids if it does not normalize. One has to look at the other markers also, especially the dynamic parameters if one has. So that is about the capillary refill time, the blood pressure, and the sensorium. Why is the heart rate high?
Sir, heart rate is high to maintain the stroke cardiac output, sir.
No, what causes the high heart rate?
Sir, sorry.
In septic shock, why does the heart rate go high?
Because of the cytokine storms, there is release of the multiple this cytokines.
Okay, also fever contributes if there is fever, right?
Yes.
If there's fever, fever
Yes,
will also make some tachycardia. Okay, move on to the next slide.
sir, to the next slide.
One sec, okay. So patient is having this thing involvement also. Patient is having involvement of the respiratory system. There is hypoxemia and there is crepitations. So why do you think this is happening?
So because of the peripheral, so leakage of the capillaries, there could be basal crepitations or uh, accumulation of fluid inside the basal zones, or they could be atelectasis post-operatively. The respiration would be hampered, leading to the atelectasis in the basal zones.
Okay, so I think if you can say this is some kind of acute lung injury because the tentative diagnosis is sepsis. Okay,
Yes,
if the patient is sepsis, this is acute, a mild ARDS, possibly patient is having mild form of ARDS or moderate form, that will depend on your PF ratio. All right, that
yes,
is the most likely cause. Crepitations can occur because of that, or like you said, it can be because of atelectasis also because of the patient being a post-operative state. Okay, and abdomen is tense, distended, and there is tenderness in epigastric and all this. So there is diffuse tenderness you have mentioned in the epigastric left chondral region, and there is guarding. You should mention where is there is guarding. You have not mentioned.
so in the left hypochondriac region only, sir.
Your examination and this thing should be more specific. The abdomen is the place where you are getting findings. You have to be more clear and more specific about the history of pain and the examination. All right.
Yes, sir. Sorry.
Okay. Move on.
So the
Yeah, this you already told. Okay. Next.
so
The other thing is you should mention about the CA gastric also, whether there were any metastasis, peripheral metastasis or anything. You have to be more clear in the history and more specific. She was operated for CA. Just show what was it? What, gastric CA or what?
Sir, gastric sir, adenocarcinoma of the stomach, sir.
Okay, so you have to also mention what stage and whether there were any metastasis. That will also have a bearing on what you are going to do. And supposing, because if there are metastasis, then you might have to consider palliative care also if she's not improving. You have to counsel the patient. So you have to be more specific, little more details have to be taken in history and examination. Next.
So for the initial management in the ER, the patient was given plasma light of 1000 ml over 1 hour and was started on noradrenaline support, which went until 0.08 microgram per kg per minute. Focus examination was done where there was no regional wall motion abnormality. There was a good contractility, no RV dilatation. The IVC diameter was 1.5 centimeter with respiratory variation of more than 50%. The lung window had a bilateral A profile, and the DVT scan was negative for the patient. After the initial 1000 ml, the IV fluid of 500 plasma light was repeated in the next 1 hour.
So why was this repeated? This was in the ER, right?
Yes, sir.
Why the plasma light was repeated after one was the IVC was seen, huh? So what are
Yes,
the
sir.
points on the IVC? What is in a spontaneously breathing patient? How good is the IVC assessment and how accurate for fluid resuscitation?
So not accurate, so with the spontaneously breathing, it is not usually advocated to use IVC variability in spontaneously breathing patients.
Yes. So it is very clear now. This came earlier. This paper, it has been 7-8 years ago when this paper came that you can use in spontaneously breathing patients. But subsequently, there have been many papers that have shown that in a spontaneously breathing patient, it cannot be used unless there are extreme variations, like it is totally collapsed or totally dilated. All right. So
Yes, sir.
this more than 50%, less than 50% does not hold true anymore. This is not accurate enough. All right, but this is commonly used because people don't have access to any other means at that time. There are no lines and all. So people still use it, but this is a very vague thing to use. What else can you do in the ER? Can you do anything else in the ER?
So
Or
passive leg rise test can be done, sir.
very
Are
good. So
the
how do you do it?
So the patient is seated initially at 45 degrees.
Hmm.
The blood pressure is recorded at that position.
Hmm.
Further, the patient is made to lie down flat with an leg elevation of 45 degree, and the blood pressure is recorded after 45 seconds or 1 minute.
Dr. Tushar, how do you do the PLRT test?
Yeah, initially the position should be propped up position 40-45 degree bed. Then gradually the head should be put on the lower the prop. It should be made straight, and then leg should be raised. Then over 30 seconds, sir, we wait, and if there is increase in the blood pressures, that is mapped, so it will help in the assessment of fluid responsiveness. Because from the venous return, from the venous return increases, so if there is increase, it will help to know the fluid responsiveness of the patient.
So can you do it in any bed, or ideally you need some kind of special bed?
So special kind of bed is required, where the legs can be elevated up till 45 degrees.
So ideally, automated bed is required, but most of our ICUs don't have automated beds. So how it is done is, what is the problem with doing it without an automated bed? What is the problem? What is something that you have to look for that should not happen? That negates the test when you do without an automated bed or even with an automated bed.
So the patient should not be the patient should not be touched during the entire procedure.
So if you don't touch, then how will you raise the legs if it is not an automated bed?
Yes.
So only it can be done with an automated bed, so where
So
the
it is ideally it is done with automated, but you can try without an automated bed also. Most of our ICUs don't have automated beds. You raise the head end to 45 degrees. Okay, then you you explain what you're doing to the patient. If the patient is having normal sensorium, record the blood pressure, lower the head end from 45 to 0, simultaneously raise both the legs slowly to around 60 degrees, and then after 1 minute you record the blood pressure again, or you have a blood pressure going on at that time, some kind of reading is going on, you see the change. All right, but there is something you have to see in that, which if that happens, then you cannot use it even without an automated bed, and that is if there is a tachycardia of the patient experiences pain, because you cannot have sympathetic stimulation. If you have
Yes.
sympathetic stimulation, then this test is negated. And sympathetic stimulation is marked by tachycardia occurring, or if the patient says she is having pain,
Yes, sir.
because it is a hemodynamic response that you see. And if you have sympathetic stimulation, the hemodynamic response that you get in your response of blood pressure will not be correct.
Yes.
So that is how you
Right,
have to
sir.
do it. And you should not get tachycardia when you do it without an automated bed. And you have to do it gently without causing pain, explain to the patient. And then if the pulse pressure, ideally it's the pulse pressure, not the systolic or the mean, which should rise, it should rise by 25%. The pulse pressure should rise by 25%. You can also use the map, but you will have the pulse pressure in front of you, right? Any recording will have diastolic and systolic. That should be going on.
Ideally, it is a stroke volume or cardiac output, which is
That is even
the
better.
validated PLR is the basically one of the any cardiac output device has to be there.
Yes, that is the ideal thing. You have a arterial line and
Classical PLR, which
yes. So cardiac output rise, how much has to be seen if you have a cardiac output device?
So it should rise by at least 20, sir, 13 to 15%, sir.
No, not correct. Tushar,
It's around 20 to 25%.
not correct. 10%. Minimal rise should be 10% in cardiac output.
Okay, sir.
But cardiac output monitor will be needed for that. And other than that, like sir has said, arterial line should be in place. You can see the arterial line. If you have an arterial line and if the pulse pressure variation decreases, that
Yes.
also helps.
Yes, sir.
But if these things are not there, then the simplest thing is the NIBP. You can just check it with the NIBP.
Yes, sir.
You should know this PLRT because it is
Yes.
more sensitive and you don't have to give any fluids for this.
Yes, sir.
Everybody should know the PLRT test. Okay. Now, coming to what else is there? Adrenaline has been started. So, should you start adrenaline simultaneously with the fluid or after fluid resuscitation?
So simultaneously, it should be started, sir, to maintain the mean arterial pressure of at least more than 65 mm of Hg.
No, is there any evidence to suggest that it should be given simultaneously or after that, or is it just arbitrary?
Studies, I don't know, sir.
No, are there I'm not asking you to quote the studies. Is there evidence to suggest that in general that adrenaline and noradrenaline should be started simultaneously or it should be started after fluid resuscitation?
Sir, it should be started simultaneously, sir, with the.
Okay, there is evidence to suggest, initially it was not like that, but over the last couple of years, there is evidence to suggest that you should start simultaneously because blood pressure targets are reached earlier. And the faster you reach the blood pressure target, the better it is. Okay. You should not keep giving fluids and wait till you are given whatever target fluid you want to give. Then start noradrenaline. Okay, next slide.
So the patient was, because of the low saturation level on the room air, the patient and with tachycardia, the patient was initiated on NIV support with an FiO2 of 0.3 and a PEEP of 8 with a pressure support of 12. Simultaneously, the blood cultures and urine routine microscopy and culture sensitivity were sent from the ER. Invasive lines, arterial and the central venous cannulation were done in the ER, and the shot of antibiotics of piperacillin, tazobactam plus metronidazole was initiated in the ER. With hydrocortisone of 100 milligram was given in the ER itself, sir.
Okay, so carry on. Dr. Jinder, your inputs, anything you want to add, please, sir? Anything?
So only here is the selection of the antibiotic. Actually, what are the principle behind the selection of the antibiotics? Generalized principle, and then we come to this.
So the principles for antibiotic selection, first the type of antibiotic, regarding the type of antibiotic to be selected, if it is the patient incidence of MRSA or the MDR has to be ruled out, sir. If the patient has a previous history of hospitalization or antibiotic uses, that has to be considered.
No. The principle is the first patient, how sick is the patient? The first principle is you have to recognize the type of the patient.
Yes, sir.
First is the how sick of the patient. Second is the what is the risk factor for MDROs.
Yes, sir.
So these are the two main principle over there. And third comes to the what could be a source. And fourth one is the possible high broad spectrum. So initial cover, it has to be a broadest. It can be logically as broad as you can add the antifungal, depending upon the. So these are the two interactions. So that's why the first of all is not the what is the risk factor for the resistance. First is the how sick is the patient sickness, and then second is the what could be a possibility of resistance, and third would be what could be a possibility of the immunity and the fungal infection. These are the basic principle, and then you add a broadest initial broad.
Okay, sir.
What about the hydrocortisone? What is the Dr. Tushar?
Yes, sir.
Can you give us some idea about why hydrocortisone was used? What is the principle behind this? What is the now we are having?
Yes, sir. So steroid, mainly glucocorticoid activity of the steroids. The few trials which were done, it had showed benefit, not the mortality benefit, but yeah, the vasopressor requirement were had shown improvement.
But
So
what is the principle? It is not the just hit and trial we are. What is
yes.
the why we are considering the glucocorticoid? What is our belief? So there would be a relative adrenal insufficiency during the septic shock
Yes.
or sepsis. That is the.
Yes.
Now, what is the present status of hydrocortisone in sepsis?
So yeah, it's there's suggestions to use hydrocortisone, so 200 mg per day dose has been suggested.
How strong? Like, is it a standard of care?
No,
What
sir.
if somebody is
When,
not using it?
yes, sir.
Can we label them he is not following a standard
No,
of?
sir. No, sir. Evidences are weak, especially advised, especially when the noradrenaline shock is severe. The noradrenaline dose is around more than 0.25 mics per kg per minute. In that case, it has been suggested to use it. Evidences do not much, sir.
So is recommendation over the years it getting little bit a weaker side over there? If
Yes.
you refer the 10-15 years back literature, then it was considered to be a relatively strong. To that level is almost a standard of care. Now, if somebody is using, then still it is okay. And somebody is not using, you can't blame them at not following the standard of care.
Okay,
So
sir.
these are the things.
Yes, sir.
Next.
So the investigation, thereafter the patient was shifted into the ICU. Meanwhile, the investigation was suggested that the hemoglobin, platelet and the TLC counts were, the HP was of 8.1, platelets of 108 with the TLC count of 32,000. Total bilirubin and direct bilirubin were of 2.6 by 1.8. OT slightly elevated SGOT and SGPT of 108 by 145 with an INR of 1.8, and the procalcitonin which was done was suggestive of 38. Other investigation CT abdomen was done from the ER itself, which suggested that there was loculated intraperitoneal fluid collection in the left upper and the mid abdomen, and some phrenic space anteriorly with bilateral minimal pleural effusion.
So, Dr. Tushar, what is the
Yes, sir.
hemoglobin low?
So, Dr. Tushar, at this level, what do you think? What kind of patient we are dealing with?
So the TLC count is very high, and liver dysfunction, suggestive of some liver dysfunction also. INR is also raised, slight transaminitis also there. Hemoglobin low could be because of, sir, because sepsis also can cause, cytokines can cause decrease in hemoglobin because of the bone marrow suppression. Those can be factors.
What is this condition? What we are dealing with? This patient came with some fluid loss, diarrhea, MI, or what we are dealing with at this stage?
Post.
So, what is our working clinical diagnosis at this moment after this much evaluation?
So you have done everything now, Dr. Tushar. The abdomen is the focus. There's a problem in the abdomen.
Yes, sir.
It is there. What kind of a patient like sir is saying we have?
Septic shock, the source mainly looks like there is intraperitoneal fluid collection also. So abdominal source, abdominal sepsis with septic shock with multi-organ dysfunction, sir. Because we have decreased urine output, liver dysfunction, and CT also suggestive of fluid overload like picture. So ARDS like picture.
So in liver dysfunction, in sepsis, what is the primary abnormality you get? Is it OTPT or is it something else?
So bilirubin should be high.
So coagulopathy would be there mostly with.
No, what is the cause of the high INR here? Is it the liver or is it something else?
There could be nutritional also, sir.
INR.
INR gets affected by nutrition in what way? Dr. Tushar, does INR
Yes, sir.
get affected by nutrition?
Uh, hmm. Can be, sir, if there is prolonged nutritional deficiency, it can cause deranged INR also.
So intake of what? Deficiency of what?
Vitamin K, sir.
Okay. So what are the causes of high INR?
So
Yes,
they
sorry.
could be consumptive coagulopathy, which would be occurring in the patient, which could cause deranged INR or.
Okay, so agreed. What else?
Sir, defective production of the coagulant factors from the liver in the acute liver injury, or if there is MODS happening MODS causing liver injury, or there could be a deficient production of the coagulant factors. So,
No, one you said is DIC, right?
yes, sir.
Second is liver injury, acute liver failure or chronic liver disease.
Yes, sir.
Mild kind of liver dysfunction usually does not cause INR prolongation. INR prolongation occurs in acute liver failure. You have to have
Yes,
severe
sir.
liver disease acutely.
Yes.
Okay, sir.
Third, Dr. Tushar had said
Yes.
there can be poor nutritional intake. What else causes high INR in general?
So, if the patient was given some anticoagulants,
And anticoagulants, okay. What else?
Yes, sir.
He's not getting anticoagulants. She's not getting, I think. Was she getting?
no, sir. No, sir. The patient had not
Okay,
received.
if the patient is getting anticoagulants, what else?
Any hematological disorder can also cause a high INR. If somebody is not having sepsis, not having DIC, not nutritionally depleted, vitamin K is adequate, still somebody can have a high INR.
So, because of some antibiotics which the patient could have received, which could cause
Okay, very good.
deranged.
Antibiotics can also cause, okay. And what
give-
else? Hematological disorders. So
Yes, sir.
different hematological disorders and also malabsorption. This patient
Yes, sir.
has tendency towards malabsorption also, right? She's
Yes, sir.
undergone gastric surgery, she had CA gastric and all that. So GI tract is not normal. All
Yes.
right. So those are the
Yes.
causes of high NR. And Dr. Swati, when you mentioned the investigations, please write complete LFT. You have not mentioned serum alkaline phosphatase, which is
Yes, sir.
the commonest abnormality in septic hepatitis. The
Right, sir.
SGOTPT is raised more in tissue hyperfusion because of shock. The
Yes,
commonest
sir.
abnormality in septic hepatitis is alkaline phosphatase abnormality. And albumin
Yes,
is
sir.
also important. Where is the albumin? You have not mentioned. Albumin becomes so important. Suppose you have to
Yes, sir.
calculate the calcium, or you have to calculate the anion gap, or you have to give albumin. Albumin should always be there. Okay.
Yes, sir.
Why is the hemoglobin low?
So, because of It could be because of the chronic illness. The patient had chronic illness, or because of the nutritional deficiency right now. Post-operatively, the hemoglobin could have been depleted, or during the surgery, pre-operatively or post-operatively, only the hemoglobin would have been 8 in the lower regions.
Okay. So she's a post-operative patient. She might have lost blood prior to that also because of chronic illness. Hemoglobin may have been low. Agreed. Or is it possible she is bleeding also?
Yes, so there could be a possibility that the patient could be bleeding, or
But they have not mentioned whether this is blood. They have done a CT abdomen,
yes,
right?
sir.
There is some collection, but this could be blood also.
Yes, sir.
But they have not mentioned. Normally, they are able to make out if there is blood or not the blood. But they have mentioned fluid collection. Okay. And
Yes, sir.
why the bilirubin high?
So because there could be obstruction in the this region, so the hepatic biliary ducts, which could be causing this rise in the bilirubin. Uh,
Hepatic biliary duct. From where are you getting the hepatic biliary duct? Alkaline for the SGOTPD is also deranged. You mean there's
yes,
a
sir.
biliary obstruction?
So the ischemic part could also cause the total bilirubin, or the rise in the bilirubin and the OTPT part. So.
No, that is more likely because they have not operated upon the biliary tract to say there's biliary obstruction. Okay,
Yes,
that
sir.
is unusual. And if there's biliary obstruction, you'll have to look at alkaline phosphatase also. That is
Yes,
why
sir.
you have to mention full LFT. You people don't mention full LFTs. You have to mention the full LFTs. Everything has to be interpreted. Okay.
Yes, sir.
Now, why is the platelet low?
So sepsis-induced thrombocytopenia, or the DIC, can occur, which could cause low in the platelet, or deficient production because of deficient production from the liver.
So, if you look at the complete picture, what is more likely? Because of sepsis, it decrease or because of DIC?
So because of the sepsis, more likely that
Why?
there is. So uh,
What is the additional laboratory test which can give you a little bit more idea about the predominant DIC, or is it just a metabolic parameter or the sepsis induced? Any other laboratory parameter which strengthen your belief? Suppose you are believing it is a DIC. So
the
yeah,
LDH levels, serum LDH levels, or the manual platelet count. So manual platelet count also.
anyway it will be low.
Yes, sir.
Fibrinogen level, sir.
Sorry,
Fibrinogen level will
fibrinogen
help
level,
to.
or before that a fibrinogen degradation product.
Yes, sir.
Yes, sir.
So you want to have a FDP, and then ultimate is if fibrinogen is less, it will strengthen your belief. If even it is a normal, then it can happen in the DIC, because fibrinogen may be a active phase reactant also.
Yes, sir.
So, what is that? How do you diagnose DIC, Dr. Swati? Is FTP diagnostic? It is the most useful test, but how do you diagnose DIC?
So for the diagnosis of DIC, they should be decrease in the they should be thrombocytopenia associated with
No, is the diagnosis clinical or is it 100% with your tests? You can diagnose on the basis of test, or is it a clinical diagnosis based on the test?
So primarily it is a contextual only. So if context is fitting, and then only you can take the help of the laboratory.
Okay, so there is a DIC scoring system. There is a DIC scoring system, and you can look at the scoring system, but even that scoring system is not 100%. It is in correlation with your clinical scenario. And FDP, like sir said, is the most important diagnostic test, single most important diagnostic test. So DIC scoring system is there, which is validated, but it is not 100% that if you get a score like this, then it has to be DIC. It has to be taken in context of the clinical picture. Okay, move on. Then you have bilateral pleural effusion also, you mentioned, right? So why are you having bilateral pleural effusion?
so it could be because of the reactionary. It could be a reactionary bilateral pleural effusion to the sepsis, or the abdominal
How do you
infection.
get bilateral pleural effusion reactive to sepsis?
Capillary leak,
So,
sir.
Capillary leak.
Yes, sir. Because of septic shock, there could be capillary
So
leak also.
is it common to get bilateral pleural effusion in sepsis without lung involvement? Have you seen bilateral pleural effusion in sepsis without fluid loading?
Mm,
Have you seen patients with bilateral pleural effusion without lung involvement and without fluid overload getting bilateral pleural effusion?
no, sir.
Then what is the cause? It does not occur like that. Only if there is lung involvement or you have overloaded the patient and albumin is low.
Okay, sir.
Initially, it is not like that. So why is there bilateral pleural effusion? What are the two causes, possible causes?
So they could be because of the fluid overload given in the given as the part of the resuscitation, or it could be because of the capillary leak or hypoalbuminemia. So there is hypoalbuminemia could also cause bilateral pleural effusion.
You have not mentioned the albumin. That is why I told you have to mention all the investigations. So one is albumin could be low. She is post-operative. All right. Second is
Yes.
it could be reactive secondary to the abdominal pathology.
Yes,
There is
sir.
the collection in the upper segment. So whenever you have abdominal pathology, you get reactive pleural effusion. Then third is there is lung injury, I think, right? She has bilateral
Yes, sir.
crepitations. There's hypoxemia, so there is ARDS, likely.
Yes.
Huh? So these are the possible
Yes.
causes of bilateral pleural effusion. Okay, move on.
Uh, so the HRCT was also done, which showed this picture with the bilateral basal regions having confluences with minimal pleural fluid.
Okay. So is this consistent with ARDS, this picture?
So it is considered, yes, sir, with ARDS it is present.
What do you get in the CT in ARDS classically?
So bilateral confluence will be seen, sir.
Confluence, is that the correct word?
The bilateral infiltrates will be seen or in the lung region, sir.
Okay. And what else do you see in ARDS picture, CT, which is seen here?
So basal predominance
Okay.
mostly.
There has to be basal predominance, so that is classic of ARDS. All
It's
right.
gravity dependent.
Right, sir.
Okay. Sir, you want to say anything? You were saying something?
Yeah, just why so the gravity dependent more this thing is.
Okay. Move on.
Sir, based upon the sepsis guidelines, I've made some presentations, sir.
What?
So these points have been taken from the sepsis guidelines.
Okay. Bolo, carry on.
For the as per the sepsis guidelines, the screening for the screening of the early treatment, the sepsis guidelines recommends against using quick SOFA score compared with the SIRS or the NEWS as a single screening tool for sepsis or the septic shock. We have to also rule out some sepsis mimics before labeling a patient as the sepsis or septic shock. The signs and symptoms of the sepsis are non-specific and often mimic multiple other diseases. There is no gold standard test to diagnose sepsis. The bedside provider cannot have a differential diagnosis of sepsis alone in a patient with organ dysfunction. A third or more of the patients initially diagnosed with sepsis turn out to have non-infectious conditions. So there are certain conditions which could mimic like a sepsis. These are the neuroleptic malignant syndrome or serotonin syndrome. Patient having malignant hyperthermia, salicylate toxicity, anticholinergic toxicity, or a patient having sympathetic toxicity, and thyroid storm or non-exertional heat stroke in some patients. The 1 hour bundle.
Just go back, Swati. So, Swati, all these mimics you have shown, how many of these you have seen in the last 1 year in your ICU?
So I've not seen any, so but these
Why
has
are
to
you
be.
saying that these are the mimics?
So these have to be ruled out before.
This is very
These
rare.
are,
You
yes,
see any of this condition comes once in 1 year, not more
yes,
than that. So, what are the mimics of sepsis? In a patient of sepsis who's
In
thought,
our context, what is the one of the commonest mimic is the pancreatitis.
Thank
you have to
yes,
call, you have to look at surge physiology. All patients
yes,
with
sir.
surge physiology are the commonest mimics of sepsis.
Yes, sir.
Pancreatitis, myocardial dysfunction. Huh? These are
Yes, sir.
whatever causes surge physiology is the commonest. Acute liver failure, sometimes even that is mimic. That is also surge physiology. Myocardial infarction with cardiogenic shock in patients who are thought to have sepsis. Okay, around 20-25% did not have sepsis or septic shock. So what are the commonest differential here? In 20 to 25% in a series, it was seen patients who were thought to have septic shock or sepsis did not have that. So what are the differential diagnoses here? What did the patients have actually? In those patients who were thought to have septic shock. What do you think? These conditions were not there. These are very rare.
Like Q SOFA, you have already mentioned, it is not strong. So consider heart failure patient. Heart failure patient always qualify Q SOFA.
Yes, sir.
Whenever he gets admission to the hospital, he always qualify Q SOFA because there would be a less blood pressure, less than 90, respiratory rate would be high, and hypoperfusion may be a neurological, this thing is maybe there.
So the commonest thing that was seen was that the patients had other kinds of shock. The commonest differential was other kinds of shock, right? In patients who were thought to have septic shock, which were not investigated properly. Second was that you were missing the etiology of septic shock. You did not investigate adequately. For example, you did the routine testing, you did not find any source. Unless you find a source, you cannot be sure if your blood cultures are negative, right? Either your blood cultures come positive, then you can be sure if you don't find a definitive source. For example, your culture is negative and there's a retrocardiac pneumonia. Retrocardiac pneumonia cannot be picked up on X-ray, and you don't do the CT. So you don't know what it is, right? If there's a focus in the GI tract and you don't do the CT abdomen, you will not pick it up. So and the culture is negative, you're not sure. So that is the other differential, that you do not investigate enough for septic shock. So you can't find the focus and your cultures are negative. Third is, for example, patient has a urosepsis and he has received a couple of antibiotics outside. Again, your urine culture, blood culture can be negative. So you won't be able to diagnose. And third is classic mimics of sepsis. Classic mimics of sepsis like surge physiology, vasculitis, some of the more common things. And sometimes it can be viral sepsis also, which cannot be picked up. Viral sepsis is also there.
Okay.
So one has to be aware of all these differentials and have collateral thinking, especially your other types of shock. This is very important, and you have to investigate deeply if you are not getting the cause of shock. Okay, Swati, move on.
So the initial 1 hour bundle, the initial resuscitation should be done. There are 5 steps, five most important considerations to be made: that measure the lactate levels, remeasure the lactate levels if the initial lactate levels were more than 2, obtain adequate blood cultures before administration of the antibiotics, administer broad spectrum antibiotics, begin rapid administration of fluid resuscitation with crystalloids of 30 ml per kg for hypertension or when the lactates are more than 4. Apply vasopressors if hypotensive during or after the fluid resuscitation to maintain a mean arterial pressure of more than 65 mm of Hg.
Dr. Tushar, you want to add
Yes.
more? This thing is related to the initial management of the sepsis.
No, sir. Means we have to give. Yeah. We have to give fluids, but we have to parallelly assess also giving fluids with 30 ml per kg. We have to do whatever dynamic options we have. So along with that, we measure and give fluids.
So 30 ml per kg for all the patient, or again, how strong this recommendation? You already recommend a weak recommendation. So that
Yes,
if it can be combined with any other thing, then we will have a more precise answer. So what kind of a thing which we, of course, if you don't access to those gadgets, then 30 ml per kg. That's why they put it as a weak.
yes,
and we take it as a all the time strong because it is some number and we find very easy to follow the number. Technically, it is a weak quality of strong, and the downgraded from strong to low quality of evidence also. It is not a very good kind of this thing. Then how we can rectify, how we can overcome the problem with this?
So using the dynamic parameters along with this.
So we can take the some kind, if we are available, then we can really ignore the number and actually individualize the patient based upon the our advanced parameter or what is the clinical context, and the typically dynamic is better than the static one. And if we combine in dynamic itself from some echocardiography study, or we combine with the dynamic with the echocardiography study, then it gives you both the side requirement as well as the safety, because now we have to really balance the fluid. It's just not the pushing of the fluid. Some people may not even have this sufficient 30 ml. They may require more than that. And the few people, this amount can be a little bit not able to they handle that. Suppose the septic patient is having a low ejection fraction, 20%. They definitely require adequate preload, but not to tuned off to that much amount on that particular time. That's why we call all the dynamic.
Yes.
At this moment, this patient may not require. After 4 hours, he may require more.
So in a nutshell, 30 ml per kg is where nothing can be done. No monitoring can be done. Otherwise, you have to individualize. Definitely 1 liter can be given in all patients. After that, you have to do monitoring and give accordingly. Static dynamic parameters should be used, and or your perfusion markers initially, and then use and then proceed. Okay, this 30 ml per kg is not really true for everybody anymore. Then this came under severe criticism also when these guidelines were published. And after that, there have been several guidelines and papers. I think you are going to show them. Just carry on.
Similarly, the 30 ml per kg should be given within 3 hours or no. So the average volume of fluid received pre-randomization was also in the range of 30 ml per kg. That's why it was suggested to give 30 ml per kg over 3 hours, suggesting that this fluid volume has been adopted in the routine clinical practice. For adults with sepsis or septic shock, we suggest using dynamic measures to guide the fluid resuscitation over physical examination or the
So,
static.
Dr. Swati, the message should not be that all patients should be given 30 ml per kg. Dr.
Yes,
Jitendra
sir.
has clearly explained. That is not
Yes,
the
sir.
message we are trying to convey. If you don't have any means of any kind of measurement of dynamics or static parameters, then it's okay. Otherwise, 1 liter, it has been suggested by Javier Monet and Jean-Louis Touboul, right? They are one of the experts in fluid, that initial resuscitation should be 10 to 15 ml per kg. All right, and thereafter you should use your parameters to assess whether the patient is fluid responsive. And it has been seen that after initial bolus, only 50% of the patients need fluids. It has been clearly seen. And it's better to use some vasopressors rather than keep pouring fluids without any kind of evidence to give fluids. Okay.
Yes.
So that's why the concept is there, and then we really need to understand, even as a clinician, not as a scientist research only. Even our patient is fluid responsive. That doesn't mean we keep on giving the fluid. One is the fluid for resuscitation, and we can take the very well help of the vasopressors and simultaneously see the safety. Probably you are resuscitating and achieving some number at the cost of overall increased mortality. So therefore, the safety has to be there. A patient may be fluid responsive even after giving the 10 liter of the fluid. When you apply the parameter, they will be fluid responsive. That doesn't mean we keep on pushing the fluid. That is again. So we have to achieve the minimal acceptable targets of the hemodynamics with the safety, and to continue the patient and apply the rescue measure, which eventually curtail the sepsis, the source control and the appropriate antibiotic. Or I think we have a little bit discussion on the present status of the antibiotic adjuvant also. Did you cover, Dr. Tushar, some? There is little bit
I think we'll move on. We'll see what comes. Let's move on. Carry on. Next slide,
Continue.
So according to the studies, they had suggested to continue with the resuscitation with crystalloids, and the Hess or the gelatin was not advised to use, or they had advised against the usage of Hess or the gelatin. Albumin can be used in patients who are requiring large amount of crystalloids.
So I would just like to add about albumin. So albumin classically, as per the sepsis guidelines, is you have rightly said, but albumin has many pleiotropic effects in sepsis beyond a volume expander. And for that to be used, you can use some albumin right in the beginning. There is some evidence to suggest that, and some trials. Okay, even the Albios and the SAFE study and the dubious study, they found some benefit in the subgroup analysis if it was given early. Okay, so if you give it early, it can have pleiotropic effects in the first 24 hours. In fact, there was one study from ILBS also recently which saw septic shock in CLD patients, and there they gave it right in the beginning, and they found that those patients responded faster and had a better outcome and discharge. So this is just a softer point, you may consider it, though this is not there in the sepsis guidelines because it has many pleiotropic effects. Albumin has many pleiotropic effects. Okay. Next.
So for adults with sepsis or septic shock, they recommend using crystalloids as the first line of fluid for resuscitation as a strong recommendation. For adults with sepsis or septic shock, using balanced crystalloids instead of normal saline for resuscitation had a weak evidence. How to avoid over and under resuscitation? The poor indicators
So,
are the
Dr.
harsh
Swati,
on
Dr. Tushar, should you give normal saline,
Yes, sir.
single lactate, or should you give plasma light for septic shock?
So if plasma light is available, can use plasma light. Otherwise, lactated ringer
What
solution.
should you start with? Is it okay to start with normal saline or single lactate?
Yes, sir. It's okay to start.
Then you said you give plasma light?
So if it's available, sir.
No, it is available everywhere. Most of the AT centers it is available. So will you go for plasma light or normal saline or single lactate?
So I will go with plasma light.
So you see, initially if you have to give some fluids, normal saline and single lactate is okay. But if the
Okay,
volume becomes large, then you have to resuscitation volume is large, then you have to use plasma light because then you will get hyperchloremia. Okay, the problem is hyperchloremia. If you get
Yes, sir.
hyperchloremia,
Yes, sir.
your GFR decreases. And the main problem is the renal effect with
Yes,
your
sir.
normal saline and plasma light difference. The difference lies in the hyperchloremia. All right, mainly
Yes.
the hyperchloremia. And once you get hyperchloremia, your GFR decreases. And that is what has been seen in a meta analysis. There has been a lot of controversy between balanced fluids and this thing, normal saline. But ultimately, the meta analysis has shown that there is some benefit of balanced fluids. This is not so much. So if the volume of resuscitative fluid is large, then you should go for balanced fluids. Otherwise, normal saline and single lactate is okay.
Okay, sir.
Huh?
An advantage is in terms of the only renal safety. The
It is
efficacy
more
is
costly also, sir. Plasma light, I think, is more expensive also to use.
so efficacy is no advantage. Even whatever little bit a kind of this thing is inclination is the only safety against the renal dysfunction. That's all.
Okay.
How does hyperchloremia cause renal dysfunction? So no, these things should be known. These are basics of critical care. The balanced fluids. So hyperchloremia causes depolarization in the arterial musculature, leading to afferent arteriolar constriction,
Vasoconstriction.
thereby decreasing GFR. These are basics. You have to know all this. Chalo, carry on.
Okay, sir.
So the poor indicators would be the heart rate, central venous pressure, and the systolic blood pressure. But the good indicators for how much to give, how much to resuscitate, and would be the dynamic parameters like using the passive leg raising or the PPV or the SVVs.
Okay, so cardiac output can also be seen by echocardiography.
Yes, sir.
So what do you see in cardiac output?
Yeah. Sir, sorry.
So can you use the cardiac output by echocardiography as a tool for resuscitation?
Yes, sir. The cardiac output can be measured using the Simpson method using the echocardiography, sir. The LVOT and the VTI can be calculated using the echocardiography, and that will help us uh, calculate the cardiac output.
That
So
would be a
the absolute
point
number.
measure only. It would not be a continuous trained. So that's why at one point of time you can measure the technically not cardiac output, only stroke volume it measures, and the Doppler based some instrument which can give you a continuous, then it would be a more useful, especially the esophageal cardiac output monitor, Doppler based.
Okay. So cardiac output, if you give the fluid challenge. So what is a fluid challenge or a fluid bolus? If you give a fluid bolus and if you see an increase of more than 10% in cardiac output, that is a static one-time cardiac output by echocardiography, not your esophageal cardiac monitor or something, then it is considered fluid responsive. So one question is what is a fluid bolus, and second question is why is 10% taken as a cutoff?
So administration of fluid bolus is administration of fluid to see the change in the fluid, to see the change or the response to the fluid administered.
Dr. Tushar, what is a fluid bolus?
200.
Fluid bolus which is causing increase in stroke volume, sir.
That is a totally different thing. How much do you give or how much time? How do you give it?
So over 1 to 2 minutes, sir, quickly. Just
Not right.
So
Dr.
these are the
Swati, what is a
mini
fluid
fluid
bolus?
challenge.
Fluid challenge on a fluid bolus. What is it?
Sir, the fluid boluses of giving 500 ml fluid in 30 minutes, or the mini challenge would be giving 200 IV fluids over 2 to 5 minutes.
So 30 minutes is not correct. See, there is no clear-cut definition of a fluid challenge or a fluid bolus. It is what is accepted is 500 ml of normal saline over 15 minutes. Huh? And the idea is you have to see the change after that. Okay, you have to see the change in your parameters after that. So if you give it over 30 minutes, the changes dissipate. So ideally it has to be given in around 10 to 15 minutes. So that is a rough guide. Okay, there is no clear-cut, precise definition, but that is the accepted definition. 500 ml of normal saline over 15 minutes. Okay,
Yes,
carry on. And why is 10% seen? In most of the definitions, you say that to assess fluid responsiveness, use 10% change in cardiac output. So why is 10% taken as a cutoff? To be fluid responsive, 10% or more increase should be there in cardiac output. So why is 10% taken as a cutoff?
I don't know, sir.
So this is because less than 10% is very difficult to estimate accurately. Okay, just this is something we should know why 10% is taken, because 10% is very difficult to estimate with the echo or any other means. Unless you have a cardiac output monitor, even that may not be so precise because even the cardiac output monitor has its problems. All right.
okay.
Okay, carry on.
For using liberal versus the restrictive fluid for resuscitation, there is insufficient evidence to make a recommendation on the use of restricted versus the liberal fluid strategies in the first 24 hours of resuscitation in patients with sepsis and septic shock who still have signs of hypoperfusion and volume depletion after the initial resuscitation. But according to the new guidelines, they suggest using either balanced crystalloids or normal saline for fluid resuscitation of patients with sepsis or the septic shock. The lactate and the CRT are as a tool to monitor the resuscitation. For adults with sepsis or septic shock, they suggest guiding resuscitation to decrease the serum lactate in patients with elevated lactate levels over not using the serum lactate alone. They also have a weak recommendation for using capillary refill time to guide the resuscitation as an adjunct to other measures of perfusion.
Dr. Tushar, can you have normal lactates in septic shock?
So can be lactates can be normal also.
Dr. Swati?
Yes, so we can have wrinkle lactates. We can have normal lactates even in septic shock. So
Okay. So what is the prognosis of these patients? Is it equally bad, worse, or better than patients with raised lactate?
so better. So with raised lactates, they have a poorer.
Okay, agreed. So patients can have normal lactate. Around 10% of the patients with septic shock have a normal lactate and they have a good prognosis. All right. So the lactate is normal does not mean that patient does not have cannot have septic shock.
Yes, sir.
Okay. So why is lactate high in septic shock?
So because of the poor perfusion, there is increased production of the lactates, and also there is decreased clearance of the lactates from the uh, there is decreased clearance, and also there is increased production of lactates.
Why
So
is lactate production increased?
because of the anaerobic glycolysis, there is a decreased perfusion into the peripheral tissues, causing anaerobic glycolysis, causing increased production.
Okay, so is the clearance also decreased?
Yes, so the clearance would also be decreased in the
Where is
lactate.
lactate cleared?
Sorry, sir.
Where is lactate cleared?
So lactates are cleared in the liver, sir.
Only in the liver or somewhere else also?
Sir, in the livers and the muscles.
Not
In
in,
kidney also, sir.
huh?
In,
In liver and kidney also, sir, some part.
Around 75% goes by the liver and 25% goes by the kidney.
Yes, sir.
And unless there is liver and renal dysfunction, the clearance is not affected. Okay,
Okay, sir.
but the production is increased.
Yes, sir.
Carry on.
so the lactates have been included in the recent definitions of septic shock, which includes there is the increase in the lactates. These suggest that there is evidence of cellular stress to accompany the refractory hypotension. Based on the earlier studies related to the goal-directed therapy and meta-analysis of multiple studies targeting reduction in the serum lactate in comparison with the standard care. The capillary refill time when advanced hemodynamic monitoring is not available, it can be used as an alternative measure for the organ perfusion. Similarly, the temperature of the extremities, the skin mottling can be has been validated to shown to be reproducible signs of tissue perfusion. The Andromeda shock study, which was done, suggested that despite the absence of a clear effect on mortality, using CRT during resuscitation has physiological plausibility and is easily performed. It is non-invasive and it does not have any cost. However, this approach should be augmented by careful, frequent, and comprehensive patient evaluation to predict or recognize the fluid overload early.
So, Dr. Swati, how do you do the capillary refill time?
So at the pulp of the finger with the glass with a glass slide, it has to be pressed at least for 10 seconds for the blanching of the skin, and thereafter after removing the glass slide, the uh, appearance of the time taken for the blanching to go is calculated. So
You're not totally correct. Dr. Tushar, you have to be very precise in this.
Yeah, from the once the blanching starts, from that time we have to wait till 10 seconds.
Absolutely.
Then
Yes. So your blanching has to occur and then you have to wait for 10 seconds. That is the
yes,
most
sir.
accepted way. That is how it was done in the Andromeda study. All right.
Yes,
And
sir.
then you have to take the time. Okay.
Yes, sir.
So we discussed the capillary refill time. Okay. That you cannot keep giving fluids if the capillary refill time does not normalize. You have to use other parameters also. But if it normalizes, then you can consider stopping the fluids. One.
Yes.
What about lactates? Is the lactates, how do you use the lactates?
So the clearance of the lactates is used. So the rapidity of the lactate clearance, it is
Yes.
recommended. Sir.
What do you expect? If you start fluid resuscitation, antibiotics, what will happen to the lactates?
So the lactate should decrease. It should be cleared or it should decrease.
So the lactate should fall.
Yes,
Yes,
sir.
sir.
So they should clear completely and you have to keep giving fluids till then or what?
No, sir. The trend of lactate fall has to be seen, sir, rather than complete clearance of the lactates.
So if the lactates fall initially, then they stop falling, then what do? You continue with the fluids or what? If the lactates are falling and then they stop falling, what does that mean?
So, sir, it could be because of there are other causes of for the rising of the lactates as
Like,
well, sir.
like what?
So the liver dysfunction, there is
Okay.
decreased clearance of the or the
So before
there
that,
is decreased clearance of the lactates.
sepsis itself is having a macrocirculation and microcirculation predominant.
Yes, sir.
So even your sepsis is the predominant microcirculatory defect, then probably even if you achieve your resuscitation, your lactate may not fall.
Okay, so like sir said, microcirculatory dysfunction, like we discussed with capillary refill time, one, right? There can be macrocirculatory filling, but they can be microcirculatory dysfunction because of shunting, thrombosis. Then
Yes.
there can be liver dysfunction. Then what else?
Sir, in decreased clearance from the kidneys, or there is excessive production, still production of the lactate. Sir.
Okay, fair enough. Then even the toxin, okay, if the cytokines are being produced, even if the perfusion is adequate, they can cause increase in lactate. Huh?
Yes.
Yes,
And
sir.
then if there is thiamine deficiency, that is another cause. And if you are giving epinephrine, that can elevate the lactate levels to some extent. So there are
Okay.
multiple other causes. So, but it has been seen that if the lactates are falling and if they are significantly low at 8 hours of resuscitation, the prognosis is much better. So
Yes.
lactates help, but they have to be taken in conjunction with everything. Huh? Okay.
Yes.
Carry on.
The vasopressor of choice, the noradrenaline, would be the first choice. If we have to add vasopressin, vasopressin can be added when the norepinephrine is in the range of 0.25 to 0.5 microgram per kg per minute. For adults with septic shock, they recommended with strong evidence to use norepinephrine as a first line agent over the other vasopressors. For adults with septic shock or norepinephrine with inadequate mean arterial pressure levels, they suggested adding vasopressin instead of escalating the dose of norepinephrine with a weak evidence. For adults with septic shock and inadequate mean arterial pressure levels despite norepinephrine and vasopressin, they are suggested adding epinephrine with a weak evidence. So now coming back onto the case.
Carry on.
Uh, After the initial resuscitation and receiving the antibiotics in the ER, and the patient was put on the NIV support initially, there was still worsening of the hemodynamics. The patient was moved on to was added on dual vasopressors with noradrenaline of 0.5 4 microgram per kg per hour and vasopressin of 2.4 units per hour. The patient had to be intubated with 8 mm of endotracheal tube and was put on mechanical ventilatory support with dual versus control mode with an FiO2 of zero point 0.5, PEEP of 8, tidal volume of 400, and resistance of respiratory rate of 22 with a peak uh, P peak of 24, P plateau of 22. The compliance was 38 and the resistance was 12. The patient was intubated in view of increased work of breathing, the drowsy sensorium, and respiratory acidosis on subsequent ABG analysis with worsening hemodynamics.
So Swati, what is the effect of noradrenaline on the heart?
Sir, it has got inotropic effect on the heart. So it causes increase in the contractility.
Okay. So it acts on which receptors?
Sir, it acts on the beta 1 receptors of the heart, sir.
And peripherally?
Sir, it acts on the alpha 1 and the alpha 1 and the alpha 2 receptors, sir.
Okay. And what are the side effects of vasopressin?
So vasopressin can causes, sir, de- mm, so it causes planktonic vasoconstriction, can cause it can cause a cutaneous necrosis, sir. There will be peripheral vasoconstriction causing cutaneous necrosis.
Okay, digital gangrene can occur, right? It causes severe vasoconstriction at times.
Yes.
Okay, so vasopressin. Then you have moved on. The resistance is 12. Is this normal resistance?
So the normal resistance should be less than 10, sir.
How much is the normal resistance on the ventilator?
Uh, so it should be less than.
It is less than 10, but you have to be more specific. Tushar, what is normal resistance on the ventilator?
Uh,
It's 3 to 7. Huh?
okay.
But it also depends on how the ventilator is calculating, because it requires constant flow and there can be problems with how it is calculating. So you have to see how it is being calculated. What is the formula for resistance on the ventilator?
Resistance.
ये तो जानना चाहिए. You should know all this.
So the
The relationship between pressure.
volume by flow into
Huh?
the con.
What is the relationship between pressure, flow, and resistance? on the ventilator?
Sorry. Sir, I did not get you, sir.
So there's a simple equation. What is the relationship between pressure, flow, and resistance? I'm giving
So
you.
pressure, yes, sir. The pressure is equals to flow into resistance, sir.
What is the resistance then?
The resistance is equals to pressure by flow, sir.
Yes. All this has to be known, huh? But this is the basics of ventilator. Okay.
Yes, sir.
Move on.
Patient underwent a diagnostic laparoscopy with pigtail insertion at the lesser sac, and the pulse calcium sensitivity was sent from the OT, and the patient was shifted back into the ICU on mechanical ventilatory support on with dual vasopressor support. The antibiotics were upgraded to meropenem, tigecycline, and fluconazole was added. So the pH was the ABG had a pH of 7.2, PCO2 of 49, with a bicarbonate of 19, lactates of 3.2, PO2 of 72, sodium of 138, and potassium of 4.2. But in the subsequent uh, laboratory evaluation, there was a rising creatinine from 1.2 to 2.2, but still the urine output was more than 0.5 ml per kg per hour.
Okay. So, Dr. Jitendra sir, please, whenever you want to contribute your questions or please free.
Yeah.
Carry on.
So, the risk factors for the Candida sepsis or the fungal infection would be the candida colonization on multiple sites. In patients with neutropenia, immunosuppression, severity in high grade severity of illness with a high Apache score, longer ICU stay, the patients who have central venous catheters and other intravascular devices, persons who have history of injectable drugs, patients on total parenteral nutrition and a history of with the use of broad spectrum antibiotics, gastrointestinal tract perforations and anastomotic leaks, emergency gastrointestinal or the hepatobiliary surgery, acute renal failure and patients on hemodialysis, severe thermal injury or the prior surgeries.
So, what is the risk factor in this patient?
So the patient had undergone a major abdominal surgery, sir, and also patient had received broad spectrum antibiotics.
Okay.
And yes, sir.
Carry on.
So the risk factors for endemic yeast or the cryptococcus or histoplasma or the blastocytes will be the patients on.
We skip that. Get too long. This is not required. Carry on.
Continuing with the case, despite persistent high vasopressor requirement and increasing FiO2 requirement, the X-ray was done, which showed bilateral lower zone infiltrations. The pH was still suggestive of type 2 respiratory failure, pH of 7.32, PCO2 of 56, and PO2 of 68 with a bicarbonate 29, and lactates gradually started to decrease with 2.6.
Why the bicarbonate is high? You have given him soda bicarb.
No, sir.
Then why the bicarbonate is high?
So as the compensation part, because there is increase respiratory acidosis persistent. So.
But the kidney is in failure. So why the bicarbonate is high? If the kidney is failure, you cannot compensate.
So, but the urine output was good in the patient.
Urine output can be good, but your creatinine is going high. Urine output, you can have some urine output sometimes.
Yes, sir.
I think the bicarbonate has been given to this patient. When the kidney is having a creatinine of 2.2, especially a lady of 60 years old, GFR is definitely around less than 30. And you cannot have bicarbonate going up like that. I think most likely you may not know I think bicarbonate has been given to this patient. One has to see the serial ABGs.
Right, sir.
Okay, and lactates are falling. So the lactates are falling. What does that mean?
So that the clearance, the liver functions is improving. The clearance is
Before liver function, what is happening to the patient? What is happening to the shock and the perfusion?
perfusion is improving, sir.
Yes, so that is a good sign. Anytime the lactates are falling, it is a good prognostic marker. Okay, so you are achieving good perfusion. That is the thing. But because of the injury already occurred, the organ dysfunction is occurring, right? And the organ dysfunction occurs not only because of tissue hypoperfusion. It also occurs because of direct cytokine-mediated injury to the organs.
Right, sir.
Okay, carry on.
So the laboratory wise, there was hemoglobin and platelet counts are further falling. The HB was 7.8 and the platelets was 798 with a TLC count of 24,000. There was further increasing in the total bilirubin, direct bilirubin, and liver function tests were worsening. The INR also had raised to 2.2, and the sodium, potassium, and creatinine. The sodium was 138. The potassium was 4.6, but the creatinine had elevated from 2.2 to 2.6. Uh,
Would you like to give FFP to this patient? INR is 2.2.
no, not required, sir. FFP until there is a risk of bleeding. So, if the patient bleeds. So.
Yeah, if the patient is bleeding, then only, or if it gets very severely deranged, then you might consider prophylactic. Okay, but at INR 2.2 and platelet of 98,000, you should also mention PTT. PTT also
Yes.
comes into the picture. It is not
Yes, sir.
only PT and platelets, APTT is also important. One has to look at all the parameters. Carry on.
For the organ dysfunction, the sepsis can cause multiple organ dysfunction. It could affect the brain, causing confusion, delirium, altered sense of consciousness, or cognitive impairment. In the lungs, it could cause pulmonary edema, diffuse alveolar damage, acute lung injury, or the ARDS. In the cardiovascular system, it could cause cardiomyopathy, ischemic, or the diastolic failure. Liver, it could cause steatosis, cholestasis, centri-acinar necrosis, or the acute liver failure. In the pancreas, it could be ischemic pancreatitis, decreased insulin production, or leading to hyperglycemia. Renal wise, it could cause acute tubular necrosis, and in adrenals, it could cause hemorrhage and lipid depletion.
So, your Swati, this slide is not totally correct. Okay. For example, cardiovascular, it does not cause dilative failure. Okay.
So,
Now, neither does it cause ischemic failure.
so it causes
No, it causes, no,
cardiomyopathy.
this is not entirely correct. Okay. Dilative failure means dilated cardiomyopathy. So, you don't get dilated cardiomyopathy in neither you get coronary ischemia. Where the ischemia coming from? Okay. So, this is not totally correct. Then adrenal hemorrhage is very rare and lipid depletion. Adrenal dysfunction occurs to some extent, and there is the decreased production of steroids. Then in the liver, centri-acinar necrosis, and all this is not so common. Necrosis is not so common. You don't get liver failure. You said liver failure. This slide should have been better. Huh? You have to choose the
Yes.
slide carefully. Okay,
Yes.
and pancreas ischemia occurs, and decreased insulin production is not so common. What is more common is insulin resistance. Decreased insulin production is not really that common. Hyperglycemia occurs because of cytokine mediated insulin resistance, not because of decreased insulin production. Okay, so you have to choose the slides carefully. Okay, next.
There was persistent oliguria with a falling further urine output of less than 0.3 ml per kg per hour for the last 6 hours, and there was further rise in the creatinine from 2.6 to 3.8. The ABG suggested of metabolic acidosis. The nephrologist was consulted, and they had started the patient on SLED. Renal modification of the antibiotics, the meropenem, hepatic modification of TG-cycline, fluconazole, and metronidazole was continued.
So, Dr. Jitendra, anything you want to ask on dialysis or anything? Comments?
So, what are the indication of renal replacement therapy? Or I also should we should have done the renal replacement therapy before?
So there
when
are
he was showing an increase in the creatinine trend.
so, but there was metabolic acidosis component, or there was not evidence, and there was no the urine output was adequate. He was responding to the treatment. But right now, the indications for the RRT would be resistant metabolic acidosis. There could be resistant hyperkalemia, the symptoms of uremic encephalopathy. Sorry, hyperuricemia.
So why don't we routinely start the preemptively? Somebody is having a decreased urine output or showing the increase in the creatinine trend. So why don't we offer routinely renal replacement therapy in those patients?
So the studies have
Why we wait for the a hyperkalemia to happen or the fluid overload to happen. We could have started before also.
So the meta-analysis, whatever was done, did not show any benefit in the early versus the delayed RRT. So that's why.
Meta-analysis or the recent trial, which is a largest trial, which was having a controversy. This is
So
a AKK
Akiki 1 and Akiki 2 trials.
2 trial,
Yes, sir.
which shows no benefit, and those, if we start early, they require a more renal replacement days.
Yes, sir.
They are having a less renal replacement free days. That means you are unnecessarily do the dialysis.
Yes, sir.
Dr. Swati, if you are having, acidosis, lactic acidosis, is it improved by bicarbonate infusions, lactic acidosis? Supposing there was lactic acidosis, pH of 7.2, would you go for renal replacement therapy or would you go for bicarbonate infusions?
So we would go for renal replacement therapy. So CRRT would be better.
Yes, so in lactic acidosis, bicarbonate does not have any role. Okay, if the pH is dropping to less than 7.2, that becomes an indication for RRT. Lactic acidosis does not benefit. And
Yes.
there was a trial recently, 2, 3, 4 years ago, on metabolic acidosis patients and having both renal failure as well as other kinds of metabolic acidosis, in which RRT showed this soda bicarbonate showed benefit. Do you know the name of the trial?
Bikara issues or something.
Yes. So what did it show, Tushar?
So it didn't show any benefits. Mortality benefit was not there. I don't clearly remember, sir.
No, it
Exactly.
showed that in patients with pH of less than 7.3 and
Yes,
renal failure and metabolic acidosis, if you give soda bicarb, these patients benefited in terms of their renal outcomes.
renal outcome.
Yeah, RRT incidence was decreased and there was a better outcome in these patients. So this
Yes.
was the first trial to actually show that soda bicarbonate helped in metabolic acidosis. And this was primarily of renal origin. Prior to
Yes, sir.
that, it was not studied well. And in
Yes, sir.
lactic acidosis, pure lactic acidosis, it is not recommended soda bicarb if the pH is
Yes.
dropping.
Yes, sir.
Next,
The patient was hemodynamically, so in continuation, the patient was hemodynamically labile and same the dual vasopressors were continued. The ECG was suggestive of sinus tachycardia on POCUS. There was no regional wall motion abnormality. The contractility was good. There was no RV dilatation. The IVC was 2.2 centimeter, but the IVC distensibility was more than 50% with a lung window bilateral A profile was seen, but the DVT scan was negative.
so Dr. Tushar, we always
Yes,
talk about the IVC size, right?
yes, sir.
So IVC size more than this or less than this. So what is the normal IVC size?
From 1.5 to 2 centimeters, sir.
No, is there any study? Have you read this anywhere?
No, sir.
So we say less than 1 centimeter. If it's less
Yes.
than 1 centimeter, then you should give fluids, right?
So if it's collapsing,
No, even less than 1 centimeter also, right?
Yes,
Is one of the criteria. If it's collapsing to some extent, right? There are
Okay,
some
sir.
criteria. But
Mhm.
Dr. Swati, what is normal IVC size in the general population?
So 0.5 to 1.5 centimeters. So the IVC normally.
So you see, there are no good studies to evaluate the normal IVC. There is only one Indian study which has seen a large cross section of the population, and the IVC size varies according to body size and height, right? Weight, height, body size, body surface area. So just to generalize and say if the diameter is so much and so much, then you should give fluids is wrong. One has to look at the body size of the patient. A patient who is less than 5 feet will have a IVC diameter of less than 1 centimeter anyway. Short height patient. And and if the patient is large, the diameter will go beyond 2 centimeter, more than 6 feet. So there is a variability, and the IVC diameter is in correlation with the body surface area, the height and weight of the patient. This is something which is not taken into consideration when we talk about the IVC.
Yes.
There are many fallacies to the IVC, and it's not a good measurement. Even on the ventilator, it is not a good marker for fluid resuscitation, let alone patients who are spontaneously breathing.
Yes.
Only if it's totally collapsing and totally dilated, then you can use it probably. Okay, move on.
The RBS monitoring was done with a target of 140 to 180 milligram per deciliter, and it was intermittent short-acting insulin was given as per the sliding scale. Patient was continued on the
How are you feeding the patient?
Initially, post-operatively till day 2, so there was no feeding initiated, but thereafter TPN was started, sir.
No, patient has a feeding dyspnostomy. So how
Yes,
was
sir.
he getting the feeds at home?
Sir, at home he was started on feeding jejunostomy, sir.
Then what? And then when she came to you, how did you feed the patient?
So subsequently TPN was initiated, sir, immediately post-operatively because there was peristaltic sounds were less.
No,
The
no,
tolerance.
post-operatively meaning what?
So after the surgery, he underwent diagnostic laparoscopy for the
It's not
pus
surgery,
collection.
right? That is a procedure. You are
Right.
the pigtail only, right? That is only a procedure. Laparotomy was done and all that. Okay. So,
Yes.
the laparotomy and pigtail, you started what? TPN.
Yes, sir, the TPN was started, sir.
So after how many days of admission did you start TPN?
So after 1.5 day, 2 days, sir, the TPN was initiated, sir.
So what was the state of shock at that time?
So the patient was still hemodynamically labile, sir, on dual vasopressors.
So can you start TPN in a patient in shock?
So
Sure.
Yes.
TPN can be started, sir. There are no evidence to suggest against starting TPN in
See, TPN can be started, sir.
No, generally TPN is preferred or enteral feeding is preferred.
generally, sir, enteral feed is preferred, sir. But if there is worsening of shock, if there is worsening of shock, or there is intolerance to the feed, or there is contraindication to the enteral feed, it cannot be started.
So what was there any contraindication to jejunostomy feeds there?
So the immediately post-operatively there was sluggish bowel movements. There was that's why the enteral feed could not be started. And post-operatively there was suspicion of that there could be some leak from the operative site, which could have caused collection around the lesser sac.
So what
That's
was
why
the
the
diagnosis? Was there a anastomotic leak or was there a perforation? What was it?
so anastomotic leak was there, sir.
So
Yeah.
was the leak secured again? What did the surgeons do?
Yes, sir. The leak was secured, sir. Intraoperatively.
So the surgeon said don't give enteral feed.
So because of the because the gut was the bowel sounds were absent, the gut was silent, so that's why the enteral feed was not started immediately post-operatively.
No, who
The surgery
suggested not
was
to give? Was it the surgeon's recommendation or what?
yes, sir, the surgeon's recommendation, sir.
So bowel sounds are not taken as a very strong marker anymore. Bowel sounds is not they may or may not be there. They're not absolutely essential to start the gut feeds. But if there was an anastomotic leak, then of course that becomes an issue. All right. And but they only inserted the pigtail or they have resutured something or done something for the anastomosis.
So the later the endoscopically the suture was the leak was
Redone.
repaired.
Okay,
Yes, sir.
repaired. So, okay, because surgery has been done on the gut and the anastomosis leak and all that, probably that's why enteral feed was not started. But you cannot start TPN also in a patient on shock who's on active vasopressors. Only when the vasopressor dose is coming down and the shock is resolving, then only you can start either TPN or enteral. Neither of them can be started in a patient who's actively in shock, who's being resuscitated. It's only once the shock is stabilized, your vasopressors are coming down, your lactates are coming down, and there is evidence of tissue perfusion. Can you start the feeding, either enteral or TPN? And TPN is not started in a shock patient because the cells are hypoxemic. If the cells are hypoxemic, how will they do the metabolism?
Right.
Okay, sir.
Okay, so this is very
Okay.
And shock resolves. Normally, the patient is improving. Your shock will start improving in 48 hours, and your
Okay.
visibility will come down. So once they start coming down, you start the feed. Whether if you preferably enteral, if you cannot give enteral, then low dose TPN.
Yes, sir.
Yes, sir.
So why is nutrition important? Is it important to maintain nutrition?
Yes, sir.
Why?
To
What happens if you do not feed the patient properly over his stay?
So the gut integrity would be lost, and there also would be further worsening of the catabolic. The patient would go into the catabolic stress. The patient would go become malnourished.
So how does malnourishment make a difference? If the
So
patient is
wound,
becoming catabolic, malnourished, how does it make a difference?
so the wound healing would be delayed.
No, that is a separate. Okay, one issue is surgical patients. Suppose he's not a surgical patient. If you don't give adequate nutrition over the stay, then what will happen?
So there will be delayed recovery of the patient. So there will be delayed recovery, and
Can we
it
increase
could,
mortality?
yes, so it would increase the mortality.
Why? Tushar, does
Sir,
adequate nutrition lead to increased mortality?
so yeah, but nutrition would be required to meet all the cellular demands, all the everything, energy.
That is very vague. What is the evidence for increased mortality? If there is increased mortality, what happens? What is the patient
And
subject?
against which you actually measure it. So if we measure it against the total caloric deficit. So if your total caloric deficit keep on decreasing, the mortality increases.
So if you have a deficit of more than 5,000 calories, mortality directly increases. Very
Okay.
clearly shown.
Yes, sir.
And one of the main things is infections, decreased susceptibility to infections and decreased immunity. And
Yeah.
definitely in surgical patients, like you showed, there can be this wound healing and all those things can be there, bed wound healing. So
Yes,
it's very important to maintain nutrition.
yes, sir.
Carry on.
DVT prophylaxis with mechanical intermittent pneumatic pumps were given. The nutrition was given with the central total parenteral nutrition with a NPC target of 2676 and the protein of 100 grams, which was variable as per D. For the recommendations of for the AKI renal replacement therapy with the IHD versus the continuous, the sepsis guidelines suggest with weak recommendation that in adults with sepsis or septic shock and AKI, using either continuous or intermittent renal replacement therapy, either can be used. In adults with sepsis or septic shock and AKI, no definitive indication for renal replacement therapy. They suggested against using the renal replacement therapy. The timing was not suggested when to start actually, the early or the late, because it did not show any difference in the mortality. Further, in the case on the later, the blood cultures and the pus cultures had abdominal pus cultures had come. The blood cultures had was suggestive of Candida tropicalis, which was sensitive to the fluconazole, which was continued thereafter. The abdominal pulse culture was suggestive of E. coli, and it was it was ESBL, sir. So it was it was sensitive to the meropenem, and it was continued with meropenem treatment. Subsequently, the patient had improved. He was weaned off from the ventilator and liberated from the ventilatory support. Hemodynamically stable, the vasopressors were off. There was improvement in the liver functions. The urine output had improved, and the renal replacement therapy had to be stopped. Physical rehabilitation and family patient counseling was continued. Feeding jejunostomy feeds were restarted with nutrition optimization.
So about Candida, which is the commonest Candida species seen in the Indian ICUs? Do you know of any study?
So Candida albicans are most commonly seen, sir.
Oh no. There was a landmark study in Indian ICUs. Which species was found to be commonest? Which Candida species? Tushar?
Sorry, sir. No idea regarding
Candida
this.
tropicalis, which you have found, was commonest in the Indian ICUs. And this study was done by Dr. Arunala K. Chakravarti, who's a known mycologist in PGI Chandigarh.
Okay, sir.
Okay, so Dr. Dichinder sir, you want to put any comments?
I think most of the things we have already discussed. There are certain things overlapping between surgeon and our intensive care practice. First of all, the enteral nutrition doesn't require the bowel sound to come over there. So technically, most of the patient, we can start the enteral nutrition even without. In this particular case, the control of leakage was not sure because the first surgery was very because the gastric and all these things. In the second reopening actually didn't give the confidence of the surgeons for the adequate control of the leak. That was the reason, not the reappearance of the bowel sound. And the leak continued over the so many days in the controlled way. That was the reason. Here little bit Candida, this Candida tropicalis, which is supposed to be over there. Otherwise, the sick patient intensive care. First, we select echinokindins, and the later on we can step down to the fluconazole if Candida is susceptible to that, except the tropicalis. Tropicalis, even the sick patient, we can give the almost 800 per day fluconazole in initial days, and we can continue the fluconazole. So these are the few things which we should keep in mind.
Why did this patient have Candida infection, Dr. Tushar? Why did he have Candida sepsis?
Because of immunocompromised state, could we say he was a known case of carcinoma stomach post-operative.
What is the main cause of the Candida sepsis?
In this case, what is the main concept?
He has shown several risk factors. What is the main reason behind Candida sepsis, which is very common?
He was started on TPN, sir.
That is later on. Sepsis already occurred.
Abdominal surgery, and the most common source of Candida is the gut only.
Gut, yes.
So whenever, even if we get the Candida positive in medical patient, that is because of translocation. And the abdominal surgery is the higher most, except the translocation, even the physical disruption, you are allowing Candida to enter into the systemic circulation. So among all these things, abdominal surgery and the leak, that would be a greatest odd for this. And of course, the rest of the things.
Always in abdominal sepsis, Candida has to be covered. Have a low threshold for covering Candida wherever the gut is compromised. Because it, like sir said, it comes from the Candida is a common cell in the gut. It comes from the gut very easily.
Yes.
In fact, one of the indications to start antifungal therapy at the outset is abdominal sepsis.
Yes.
Okay. Any questions from you, Toshar or Swati? Want to ask any clarifications?
Sir, regarding TPN, I wanted to ask, even the shock is, in general, I am asking, sir, if the patient is requiring vasopressor not very high, and we are not able to give enteral feed for other indications, so can we still start TPN or?
You cannot give TPN unless the patient's perfusing. If the patient on tapering doses of vasopressors, if the patient is improving, falling lactates, then you can give. But if the patient is hemodynamically unstable, requiring higher dose, moderate doses of vasopressors, you are still actively resuscitating, then you cannot. It is very clear.
Okay.
So again, here are two concepts. One is the first of all, you want to start the nutrition or not. That is the one issue, and then we go to the TPN. Till the patient is not resuscitated, you actually ignore the nutrition.
Okay, sir.
The second come to the nutrition. Once the resuscitation, then the nutrition. Even the small mild dose enteral can be given, and the moderate dose. Now the question comes the TPN. So depending upon the situation and what guideline you are following, the European guideline keep it as a 3 days. American it extend up to the 7 days. So your patient is unlikely to start to meet the nutrition for the 7 days. Either you pass 7 days, or right from the beginning you anticipate it is going beyond 7 days. Then you can start the TPN.
Yeah. Yes.
So suppose if you postpone your nutrition for 5 days, and 5th, 6th day you are able to start the enteral nutrition, then according to the guideline from this perspective, you are not supposed to start the TPN.
Okay.
And along with your standard calories, you have to take care of the micronutrients, the vitamin D, and all these things are also important. Even vitamin D should be measured, and if it's low, it should be given. And patients getting TPN should get multivitamin supplements because they don't have trace
Yes, sir.
elements. All
Yes,
these
sir.
things. So nutrition also a little bit is important. One should know the proper guidelines and the proper care of nutrition. So, any questions, Dr. Swati?
No, sir. Thank you, sir.
Okay. So I think with that, we'll close. Dr. Jitendra sir, thank you very much. Dr. Swati, thank you for making the presentation, and Dr. Tushar for making such a nice presentation. Thank you so much.
Thank you so much.
Okay. So thank you, everybody. Thank you, Jitendra sir. Thank you very much. We'll close the
Thank
session.
you.
Thank you. It
Thank
was
you, sir.
excellent session.
Thank you, sir.